Bismillahirrahmanirrahim. Today we will discuss the laryngeal paralysis. Before we start laryngeal paralysis, it is important to study the motor and sensory supply of the larynx. First, the motor supply. All muscles except cricothyroid, which move the vocal cords, they are supplied by the laryngeal nerve. These muscles are abductors, adductors, and tensors. All these they are supplied by the recurrent laryngeal nerve of the vagus nerve. The cricothyroid muscle. This is supplied by the external laryngeal nerve, which is a branch of superior laryngeal nerve. Sensory supply. Above the vocal cords, internal laryngeal nerve, which is a branch of superior laryngeal nerve, supplies the larynx. Whereas below the vocal cords, the larynx is supplied by the recurrent laryngeal nerve. Now, this is the course of the recurrent laryngeal nerve. This figure is showing the left vagus nerve. This is the left vagus nerve, and this is the left recurrent laryngeal nerve, and this one is the superior laryngeal nerve, which comes from the left vagus nerve at the level of the hide bone, and then it supplies the larynx and trachea. And this is the main trunk of the vagus, and this is the left recurrent laryngeal nerve, which is given off from the vagus nerve near the arch of aorta. Then it ascends below the arch of aorta by forming a hook, and then it ascends in the neck to supply the larynx. This is the left recurrent laryngeal nerve, which is shown by the blue color. This is the figure which is showing the both right and left recurrent laryngeal nerves. You can see here that this is the left one and this is the right one. This is the left superior laryngeal nerve, and this is the left main vagus nerve, and this is the left recurrent laryngeal nerve, which arches around the arch of aorta and ascends in the neck to supply the left side of the larynx. On the other hand, this is the right vagus nerve, and this is the right superior laryngeal nerve, which is given off from the right main trunk of the vagus at the level of the hide bone, and then it divides into internal branch, and this is the external branch. And then this is the right main trunk of the vagus, and this is the right recurrent laryngeal nerve, which is given off at the level of the right thoracocervical trunk. This is the right thoracocervical trunk, and this is the right recurrent laryngeal nerve. Now you can compare both these two recurrent laryngeal nerves. This left one is having a long course, and then it ascends in the neck, whereas the right recurrent laryngeal nerve is having a short course. So chances of trauma and chances of disease affecting the left recurrent nerve is more as compared to the right recurrent laryngeal nerve, due to this lengthy course of the left recurrent laryngeal nerve in the neck. Classification of laryngeal paralysis. We can classify the laryngeal paralysis into by different ways. One is depending upon the origin of the cause. According to this, we can divide the laryngeal paralysis into congenital laryngeal paralysis, second into acquired laryngeal paralysis. Similarly, we can classify the laryngeal paralysis depending upon the side involved, unilateral paralysis or bilateral paralysis, according to this mode of classification. The third one is the depending upon the nerve involved. According to this classification, we can classify the laryngeal paralysis into three main categories. One is recurrent laryngeal nerve paralysis. Also, we can call it as abductor paralysis. Second is superior laryngeal nerve paralysis, also known as adductor paralysis. And third is the combined or complete paralysis. Now, in this combined or complete paralysis, there will be paralysis of both recurrent laryngeal and superior laryngeal nerves. Etiology of laryngeal paralysis. Etiology may be congenital causes or the causes may be acquired ones. Etiology of congenital laryngeal paralysis. First, unilateral cause. In this we may have birth trauma. Second, some congenital anomaly of the great vessel or congenital anomaly of the heart. Then bilateral congenital laryngeal paralysis. In this we have hydrocephalus, intracranial hemorrhage during birth, meningocele, and agenesis of cerebrum or nucleus ambiguous. These are the bilateral congenital laryngeal paralysis in which we can have all these different etiologies of bilateral congenital laryngeal paralysis. Acquired causes. In topographical manner, the causes are supranuclear causes, then nuclear causes, high vagal causes, low vagal causes or recurrent laryngeal nerve paralysis, then systemic causes, and lastly the idiopathic causes. First, supranuclear causes. These causes are very, very rare. Then nuclear causes. In nuclear causes, there is involvement of the nucleus ambiguous in the medulla oblongata. And in the nuclear causes, there is associated paralysis of other cranial nerves and neural pathways as well. The causes are vascular causes, neoplastic causes, motor neuron disease, polio, and syringobulbia. These all causes, they may cause nuclear causes. The third one is the high vagal causes. In high vagal causes, there will be combined or complete paralysis. Then both recurrent laryngeal and superior laryngeal nerves are involved in high vagal causes when there is combined or complete paralysis. The causes are intracranial, for example, tumors of the posterior fossa and tuberculous meningitis. Second, skull base causes, for example, fractures of the base of the skull, carcinoma of the nasopharynx, and glomus tumors. Similarly, causes in the neck or parapharyngeal space, for example, penetrating injury, parapharyngeal space tumors, metastatic lymph nodes, and lymphoma. Then low vagal causes are recurrent laryngeal nerve paralysis. These are the most common causes of recurrent laryngeal nerve paralysis. These may be on the right side, these may be on the left side, or they may be on both right and left side, or you can say bilateral recurrent laryngeal nerve paralysis. First, the causes which may cause right side causes of right-sided recurrent nerve. These causes may be found in the neck, in the mediastinum, or sometimes the cause may be idiopathic one. In the neck, The important one causes are neck trauma, benign or malignant thyroid disease, thyroid surgery, malignancy of the cervical esophagus, and cervical lymphadenopathy. In the mediastinum, the causes may we may have carcinoma of the apex of the right lung and tuberculosis of the cervical pleura. And as I have said, if we don't find any cause in the neck or mediastinum, then we label that disease as idiopathic cause for recurrent laryngeal nerve paralysis. On the left side of the neck, on the left side, causes are in the neck, in the mediastinum, and in the similarly we can label as idiopathic cause. In the neck, the same causes which cause on the right side, they may also cause may be found on the left side as well in the neck. But on the other hand, in the mediastinum, the cause may be a different one. For example, in the mediastinum, we may have bronchogenic carcinoma of the lung, carcinoma of the thoracic esophagus, aneurysm of aorta, mediastinum lymphadenopathy, enlarged left auricle of the heart, intrathoracic surgery. And when we found no cause, then we label that case as idiopathic. The mediastinum causes are seen on the left side because the left-sided recurrent laryngeal nerve is having a long course because it is having a course in the neck and then in the chest, that is in the mediastinum, and then after crossing the arch of aorta, it ascends again to reach in the neck. So mediastinal causes, they are found on the left side only, not on the right side. Especially the bronchogenic carcinoma is very important on the left side. Therefore, always exclude this cause by X-ray chest PA view, CT scan or MRI of the chest, bronchoscopy, and biopsy. All these will help to rule out bronchogenic carcinoma on the left side, recurrent laryngeal nerve paralysis. Causes on both sides of the neck. The causes may be thyroid surgery, carcinoma of the thyroid, carcinoma of the cervical esophagus, and cervical lymphadenopathy. Then there are some systemic diseases which may also cause recurrent laryngeal nerve paralysis. These causes are diabetes mellitus, syphilis, diphtheria, typhoid, and lead poisoning. And when we found no cause after all investigations, then we label that case as idiopathic. And it has been observed that in about 30% of the cases of recurrent laryngeal nerve paralysis, the cases we will label the case as idiopathic. We could not find the cause in idiopathic cases of recurrent laryngeal nerve paralysis. Now we discuss the management of vocal cord paralysis. How we can manage the vocal cord paralysis. Now management consists of history, physical examination of the patient, and investigations. Investigations for to locate the site of the lesion and to know the cause of the lesion. And then after when these site and cause of the lesion are found, then we will treat the patient. First of all, we take up the history. Listen the voice of the patient during history taking. This is very, very important. If the patient is having forced whisper during history taking, then it means the patient may be having organic adductor paralysis. If the patient is having a faint whisper, then functional adductor paralysis. If the voice is normal in the morning but tires gradually during the day, it means that the patient may be having unilateral abductor paralysis. Similarly, if the patient is having stridor or noisy breathing, then it means the patient may be having bilateral abductor paralysis. Similarly, ask about the aspiration in the history. If the patient is having aspiration, it means the patient is having bilateral adductor paralysis. History of some surgical procedure in the neck should also be inquired from the patient having some sort of recurrent laryngeal paralysis, for example, thyroid surgery. Similarly, inquire regarding hoarseness, dysphagia, sore throat, pain in the ears, cough, hemoptysis, neck swellings, smoking habits, any recent illness, and history of tuberculosis, carcinoma of the nasopharynx, etc. All these must be inquired from the patient in details. Physical examination of the patient. First, general physical examination for pallor, chylonychia, clubbing, and neck lymph nodes. Second, examination of the head and neck, especially thyroid examination, laryngeal framework examination, and examination of the cervical lymph nodes. Then perform indirect laryngoscopy, very, very important because it may give you an idea about the paralyzed vocal cord on ideal. The signs of a paralyzed vocal cord on ideal are, first of all, look the cord position, whether it is a paramedian position or cadaveric position. Then look at the cord, whether the cord is at lower level, the cord is atrophic, whether the cord is bowing, and anterior rotation of the arytm. All these signs must be seen on ideal, which may point regarding the vocal cord paralysis. Then examination of the ear, nose, and throat should be performed in details. Examination of the respiratory system for pulmonary tuberculosis, bronchogenic carcinoma of the lungs, examination of the cardiovascular system, examination of the central nervous system, especially for sensory system, motor system, and all the cranial nerves must be done in a patient having vocal cord paralysis. Then investigations. According to the disease suspected, the patient is asked to have certain investigations. Anyhow, the investigations usually asked from these patients are number one, CBC, urine albumin sugar, blood urea sugar, serum creatinine, tests for syphilis, tests for tuberculosis, for example, blood ESR, Martu test, sputum for acid fast bacilli, TB dot test, PCR for mycobacterium tuberculosis, and X-ray chest PAV. Similarly, certain radiological investigations are also important in these patients. For example, X-ray chest PAV, which may show carcinoma of the bronchus, tuberculosis, heart size. Similarly, X-rays barium swallow, which may give an hint regarding carcinoma of the esophagus, compression of the esophagus from outside, for example, goiter, left atrium, lymphoma of the mediastinum. Similarly, X-rays base of the skull, X-rays soft tissue nasopharynx, lateral view, thyroid scan if goiter is there, CT scan from base of skull to the diaphragm, and MRI of the brain, neck, and chest may be required in certain cases. Similarly, diagnostic endoscopy, that is called pan endoscopy, which may involve nasopharyngoscopy and biopsy, then esophagoscopy, direct laryngoscopy, bronchoscopy, and mediastinoscopy. All these endoscopic examinations are also mandatory to reach the diagnosis which may cause the recurrent laryngeal nerve paralysis. Treatment. It requires find the pathology and treat the pathology, number one. Secondly, identify the type of the vocal cord paralysis and then its treatment. It means unilateral abductor paralysis. If it is found, then treat it accordingly. Similarly, if the patient is having bilateral abductor paralysis, then accordingly bilateral abductor paralysis treatment will be required in that patient. Similarly, unilateral adductor paralysis, bilateral adductor paralysis, or unilateral or bilateral combined paralysis. So according to the paralysis, the patient will be offered the type of the treatment required for that particular type of paralysis. Thank you very much for listening.